Scabies infection, understanding pathophysiology and evidence-based treatment approaches. Scabies is a parasitic skin infestation caused by Sarcoptes scabiei mites, characterized by intense pruritus and rash. Effective treatment requires understanding transmission patterns and applying appropriate therapeutic interventions. Understanding scabies, definition and epidemiology. Scabies represents one of the most prevalent parasitic skin conditions affecting humans worldwide, with particular significance in developing nations and resource-limited settings. The disease results from infestation with microscopic arthropods measuring between 0.2 and 0.45 millimeters in length, belonging to the species Sarcoptes scabiei var. Hominis. This obligate human parasite has adapted over millennia to inhabit the epidermis and cause characteristic inflammatory responses. The condition carries substantial public health implications, particularly in congregate living environments where transmission occurs more readily. Understanding the fundamental characteristics of this mite and its interaction with human skin is essential for appropriate diagnosis and management. Transmission and risk factors. Transmission of scabies occurs primarily through direct skin-to-skin contact with an infected individual. The mites cannot survive extended periods away from human skin, making prolonged contact necessary for successful transmission. Healthcare workers, family members, and close contacts face heightened exposure risk. Certain populations experience disproportionately high infection rates due to environmental and social factors. Immunocompromised individuals may develop more severe manifestations and require modified treatment approaches. Key points: care home and long-term facility residents experience endemic transmission patterns. School-aged children in crowded conditions demonstrate increased susceptibility. Refugee camps and institutional settings create favorable conditions for rapid spread. Prison populations face elevated transmission rates due to close quarters. Clinical presentation and symptomatology. The clinical manifestations of scabies vary considerably depending on whether the infection represents an initial exposure or a reinfection. Primary infections typically generate symptoms only after an incubation period spanning 2 to 6 weeks, during which mite populations expand and sensitization develops. This delayed response often leads to diagnostic challenges and continued transmission before recognition. Secondary infections, occurring in individuals with prior scabies exposure, produce symptoms with remarkable rapidity, often within 24 hours of re-exposure. This abbreviated timeline reflects the immune system's heightened responsiveness to mite antigens and their metabolic byproducts. Key points: intense pruritus represents the hallmark symptom, frequently worsening during nocturnal hours. Polymorphic rash patterns include papules resembling acne-like lesions across multiple body regions. Burrows appear as tiny linear or S-shaped tracts where female mites tunnel through stratum corneum. Typical distribution involves wrists, interdigital spaces, waistline, buttocks, and genital areas. Pathophysiology and disease mechanisms. The underlying mechanisms driving scabies symptoms involve complex immune and inflammatory responses rather than direct mite toxicity. Female mites burrow within the epidermis, depositing eggs and feces throughout their life cycle. The body's response to mite proteins, enzymatic secretions, and fecal material triggers profound inflammatory reactions. This explains why pruritus intensity often bears little relationship to mite burden and why symptomatic improvement may lag behind successful parasite eradication. Understanding these mechanisms guides both symptomatic management and therapeutic timing. The inflammatory cascade involves multiple cytokines and immune cell populations, creating a self-perpetuating itch-scratch cycle that can cause significant skin barrier disruption and secondary complications. Diagnostic approaches. Diagnosis of scabies relies predominantly on clinical recognition of characteristic history and physical findings, as confirmatory testing remains technically challenging in routine practice. Visualization of burrows under magnification provides strong diagnostic support when present, though their absence does not exclude disease. Several diagnostic methods exist but vary in availability and practical utility. Dermatoscopic examination has improved sensitivity for burrow detection in experienced hands. Microbiological confirmation through scrapings or biopsy specimens can establish parasitologic confirmation but adds cost and complexity without necessarily altering management decisions. The constellation of severe itching, characteristic distribution pattern, and response to specific therapy often constitutes sufficient diagnostic certainty for treatment initiation. Key points: clinical history documenting progressive itching and recent exposure provides crucial context. Visual inspection of typical distribution sites guides examination focus. Magnification devices enhance visualization of subtle burrow morphology. Dermoscopy permits enhanced visualization of mite structures and burrows. First-line pharmacological treatments. Topical acaricidal agents represent the gold standard for scabies management in most patient populations. Permethrin, a synthetic pyrethroid compound with low mammalian toxicity, demonstrates excellent efficacy and rapid action against Sarcoptes mites across all life stages. Application of a 5% cream preparation to affected skin regions followed by a second application 1 week later achieves cure rates exceeding 95% in appropriately selected patients. The medication acts through disruption of mite sodium channel function, leading to paralysis and death. Proper application technique, emphasizing complete skin coverage below the neck and appropriate duration of contact, significantly influences treatment success. Patients require clear written and verbal instructions regarding application methodology and timing. Key points: permethrin 5% cream applied topically represents preferred first-line therapy in most populations. Application from neck downward ensures coverage of typical distribution sites. 8 to 14-hour contact time permits adequate parasite exposure before washing. Second application after 1 week targets mites hatching from eggs during initial treatment. Alternative and adjunctive treatments. Multiple alternative medications provide efficacy for patients unable to tolerate or access permethrin-based therapy. Benzyl benzoate, an organic compound with acaricidal properties, demonstrates effectiveness comparable to permethrin in many studies. This agent requires careful application to avoid irritation, particularly in sensitive skin areas, and remains less expensive than permethrin in some regions. Sulfur preparations, though slower acting and requiring more frequent application, offer advantages in vulnerable populations including infants and pregnant women. Oral antiparasitic medications provide convenient alternatives for patients unable to comply with topical regimens or those with extensive disease burden. Systemic agents may prove particularly valuable in institutional settings where rapid disease control prevents ongoing transmission among multiple residents. Key points: benzyl benzoate 10 to 25% solutions applied twice daily for 3 to 5 consecutive days achieve favorable cure rates. Sulfur preparations, 5 to 10%, appear safer in infants and pregnant patients despite slower action. Crotamycin represents an alternative for patients with mild disease or contraindications to other agents. Ivermectin administered orally, 200 micrograms per kilogram repeated after 1 week, offers convenience for widespread or institutional infections. Managing secondary complications and pruritus. The intense itching associated with scabies frequently drives patients to vigorous scratching, which compromises skin integrity and creates opportunities for bacterial superinfection. Secondary impetigo or cellulitis can develop rapidly and may become clinically more prominent than the primary parasitic infection. Management must address both the parasite eradication and the resulting inflammatory state. Antihistamines, while not directly affecting mite burden, provide symptomatic relief that reduces the urge to scratch. Topical corticosteroids help suppress inflammation and pruritus, though they require careful consideration regarding potential immunosuppressive effects on parasite control. The prolonged inflammatory response that may persist after successful mite eradication necessitates symptomatic support for weeks following definitive treatment completion. Key points: First-generation antihistamines provide sedating effects that may improve nocturnal symptoms. Emollients and gentle skin care minimize barrier disruption and secondary complications. Topical corticosteroids applied to affected areas reduce inflammation without compromising acaricidal treatment. Systemic antibiotics become necessary when secondary bacterial infection develops. Treatment considerations in special populations. Certain patient groups require modified therapeutic approaches due to age, physiologic status, or immunologic factors. Infants and very young children may experience more extensive disease, including head and facial involvement, necessitating careful medication selection to minimize systemic absorption. Pregnant women require agents with established safety profiles, limiting options to topical permethrin and sulfur preparations. Immunocompromised patients, particularly those with advanced HIV disease, may develop crusted, Norwegian, scabies characterized by massive mite burdens and atypical clinical presentations. These individuals frequently require more aggressive treatment regimens, longer courses of therapy, and closer monitoring for treatment failure. Elderly patients in care facilities require pragmatic approaches balancing efficacy with feasibility in institutional settings. Infection control and prevention in institutional settings. Preventing scabies transmission in congregate settings demands systematic infection control measures coordinated across all staff and residents. Identifying cases promptly through surveillance and education enables timely intervention before widespread transmission. Simultaneous treatment of all symptomatic individuals and close contacts prevents reinfection cycles. Environmental management, including appropriate laundering of bedding and personal items, reduces transmission risk, though mites cannot survive extended periods away from human skin. Staff education regarding symptoms and transmission routes facilitates early case identification. Documentation of infection control procedures ensures accountability and guides outbreak response when multiple cases occur. Crowded institutional settings require heightened vigilance and may benefit from periodic population-wide screening and treatment to eliminate endemic transmission. Monitoring response and managing treatment failure. Following treatment initiation, patients should experience progressive symptom improvement within 1 to 2 weeks, though complete resolution may require several additional weeks due to persistent inflammation. Failure to improve by this timeline suggests either inadequate application of topical agents, reinfection from untreated contacts, or misdiagnosis. Re-examination of the patient and assessment of application technique helps identify modifiable factors. Some cases of apparent treatment failure actually represent delayed inflammatory resolution rather than persistent parasitic infection. Confirmation of persistent mites through repeat microscopic examination helps distinguish true treatment failures requiring alternative agents from inflammatory sequelae. Repeat treatment with an alternative acaricide may benefit patients with documented treatment failure, though such cases remain uncommon with appropriate initial therapy. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.